My understanding is that luteal phase deficiency is something like we'll be today focusing on luteal phase in ART only. That will be my the point of contention of these things written here. You all know about it, but today we're going to talk about ART, how ART disrupts the luteal phase defect. So LH role is not only ovulation but also maintaining a corpus luteum. And this is another figure which shows that we have premature surges of LH coming. Before ovulation, LH is a villain. But in case there is no LH, then there can't be any fertilization. And it's not only that LH acts upon the corpus luteum, but LH will also act upon and that there is at some point of time LH deficiency. And then LH deficiency will mean finally we'll also have progesterone deficiency. So these are a few things which I'm going to like this. So for good outcome, we have picograms of V2, one mature follicle of 20 millimeter. So when there are 10 of them, we'll have multiple follicles and then we'll have around 2500 to 3000 picograms of E2. So here E2 goes very high, and when E2 goes very high, we are having a cycle with GnRH analogs, and we have a cycle with GnRH antagonist and GnRH agonist trigger. We'll find that the being sold in the market, it is not meant to be given orally, and they tell you also. But I've seen so many people, do goli subah sham kha lo, two capsules subah sham kha lo, or there are I combine intramuscular and vaginal. So you have to pick up your own jobs. You have to know that parenterally, initially we were giving parenteral only. So parenteral may, this is the initial method on the buttocks. So it's painful, actually very painful. So I'll tell everyone again that before you advise as a gynec, you must take 1 day course of AKT. Take 400 milligram of progesterone. You also take 1 tablet of 𝐾𝐞10 and also take 1 intramuscular injection of progesterone. You'll know what a woman goes through actually. You'll probably be more pragmatic in your treatment. Oral is not to be given, natural not to be given, synthetic can be given, transdermal not to be given. Because the enzymes in the skin will degrade it. Vaginal is a beautiful green everywhere. It can be given. So these two methods are the best methods you can use. Bioavailability of dydrogesterone, which is called a retroprogesterone, compared with micronized progesterone, there are multiple papers, multiple studies. There's a Lotus 1 trial, Lotus 2 trial. So their trials are coming from the pharma companies. They say my drug is better, my drug is better, my drug. So oral progesterones like dydrogesterone were never in vogue. So now they have come out with many studies by Lotus 1 and Lotus 2 trial. Lotus 1 was with vaginal progesterones and so they compared with micronized progesterones. They compared with in one study, and they found that it is a non-inferior. Both Lotus 1 and Lotus 2 said that oral dydrogesterone has got good outcome, good bioavailability, but and less amount of dosage it can be absorbed. So these are few studies, Lotus 1, Lotus 2 trials, but the final study, which I'm going to send to you in next 15-20 minutes, a beautiful one, read that once. So when do we start that treatment? Debatable. You won't believe it that I won't name the institutions, the top institutions of the country, when they started with the OPU, they had 0% pregnancy rate because they forgot to give progesterone support. They forgot. I'm talking about year 2002 and 3. At that time, there was no teaching. We all had to, I've traveled to around 5 countries to learn IVF. In India, things were not that easily available at that time. So support, when do we start, is very, very important. I normally prefer to give support on the day of oocyte retrieval. But nowadays, we are not doing much of fresh transfers. So we start the support when the endometrium is minimum 8 millimeter. The blood supply is zone 3. And the levels of P4, I always do a P4 nowadays because in private We have to give the best possible outcome. We can't even lose one pregnancy. The P4 should be less than 1.2 nanograms per ml. These three things when I get, I'll start the progesterones. In my career, I used to forget to start progesterones. Today we do the OPU and we forget giving progesterone. We give it after 1 day or 2 days. I found there was not much of a difference. And the same thing has come in this study also, which I'm going to send to you very quickly. Day of OPU, day after OPU, day of embryo transfer. Day of embryo transfer means normally it's a day 2 of embryo transfer. Day 2 embryo transfer when we carry out, we find that actually it is fine. So luteal phase support, just remember that it should ideally start on the day of pickup or do it day 2 of the day after pickup. And when we are doing a frozen embryo transfer cycle, I've told you these are the criteria, the must criteria. Minimum 7 millimeter, I prefer 8 millimeter, and P4 values in case the patient can afford, do it. In IUI cycles, there is no LPS, no luteal phase support in IUI cycles until you have given controlled ovarian hyperstimulation. Algorithm of LPS applies to FET cycle, antagonist cycle, agonist cycle, IUI cycle. There are different methods. In IUI cycle, we give it the day we have done the IUI. The day we have done the IUI, we start with the luteal phase support. In agonist cycle and an antagonist cycle, I've told you, give it on day of OPU straight away. But now what we have learned is that in antac cycle and an agonist cycle, we are always going in for FET cycles. So in FET cycle, things have become very simple for us. When to stop the LPS? शुरू तो कर दिया है, इसे बंद कब करना है अभी? इसके बारे में इनके से look at it. Day of positive beta HCG, stop it. Day of fetal heartbeat, stop it and continue till around 10 weeks, 70 days. Choice is yours. I'm actually scared. I stop at 70 days. In the government, we did a lot of cases. We stop at around 6 weeks or 5 weeks. It was okay. But in the we're stopping at around 70 days, which you can also do. Which is a better progesterone? It all depends upon the bioavailability, side effect, ease of use, outcome. So we have compared all. Just remember that oral micronized progesterones not to be used. Synthetic, go ahead. Intramuscular complications, but good. And the best is the vaginal. But even vaginal, a lady is working. She'll have to put in the vagina 2 or 3 times a day. She'll have to go to the washroom. She's working. And that's a problem. It can have vaginal irritation. A lot of people have such bad side effects of progesterones, I can't tell you. After even stopping progesterones, they have rashes for 8 to 10 days. These we have to focus. So some debates, I'm just going to close now. So there are some debates about dydrogesterone and vaginal micronized progesterone availability, safety and tolerability. This was oral versus vaginal. So they found that both are actually equally good, and they spoke about non-inferiority of the oral route. They both are equally good. And then there's a debate about intramuscular versus oil-based. Intramuscular progesterone versus, meaning oil versus aqueous. So this is 100 milligram and this is 50 milligram or 25 milligram. It works very well. But I still like to go in for an oil-based progesterone. I feel more safety to it. But there are studies which say that 25 and 50 are same and they are as good as any other method. I'm going to send you one article just now. Transdermal not to be given, and the P4 is got a molecule which is coated with cyclodextrin. It works pretty well, and that is as good as the vaginal route. So oral synthetic versus vaginal progesterone was the Lotus 1 trial, and then we had one more Lotus 2 trial where they compared synthetic oral versus 8% vaginal gel. So they both found that they work actually equally well. So take home message is the supplementation of progesterone is very important when we give any patient do anybody's IVF or IUI stimulation is important. You can start it on day 1 or day 2 of pickup. Day after pickup you can start. Nowadays we are doing FET cycles, and in the FET cycles we start when the endometrium is, I'm repeating, is around 8 millimeter, zone 3 vascularity, and we also find that there is the morphology is perfectly fine. We can start prosgesterone, and nowadays sometimes people are demanding we carry out also, and we continue till nowadays. In IUI cycles, it is not recommended. For a routine clomiphene or letrozole cycle, it is not recommended. It won't give you any help. It may cause good or not, or bad or not, but it won't help you. And people spend around 200 rupees per day. So that should be avoided. So the total price of progesterone support should be around 200 per day, and this for around 15 days. This is the amount of money that people spend. So I feel that around 3,500 rupees is the price of luteal phase support for an average patient. So to conclude, I like to say that whenever we pick up I've told you something very, very pertinent, that oral natural micronized progesterone not to be given. Don't give it. Try to keep the package to around 200 rupees per day. These prices which I've quoted to you are the prices from the mobile phone, from Easy Pharmacy, not from the pharma at all. This is important for you to know, and should also remember that the day of start and day of stopping is important. This you have to understand. You can stop it the day you get the fetal heart rate positivity. That's all. I've ended my talk. I have taken precisely around 1 hour and 2 minutes. Thank you so much for being with me. So now I think we'll open. I'll see you all on my screen.
Thank you. Thank you, sir.
Thank you, Pooja.
Thank you for the wonderful presentation. And so we have few questions in the chat box. I would request you to please open the chat box.
I just want to make a comment.
Hello.
It was a wonderful, wonderful talk, especially for the beginners. And so many queries, so many things have already been cleared. I hardly think any question has been left.
We'll answer them together. Be with me, ma'am.
It's Dr. Pankaj, it was really a wonderful talk. So many confusions according about progesterone, oral, intramuscular, and this aqueous preparation. I don't know at what places so many aqueous preparations are available. I don't think people are using aqueous really. And intramuscular and gel.
People are using, ma'am. Very frequently people are using.
Okay.
I have my reservations, but it's a good product, ma'am. The whole world says we can use it. It's my bad experience, probably. People are using it. But use 50. Don't use 25, I like to say.
What about
we haven't used aqueous preparation. But it was really a very clear cut and lot of good messages.
Thank you, ma'am.
Confusions
solved. Sir, what about depot progesterones?
Ma'am, many people use depot progesterones.
So when would you advise them ideally?
Ma'am, they start the day we start. Ma'am, the main thing is that day we start progesterone. That day is the day of starting. You can give any progesterone. Many people use depot progesterone. They use caproate or I don't use them anymore. Hydroxycaproate 500 milligram. So you can start it the day we want to start progesterone and keep repeating it. They give to 50 milligram bi-weekly, ma'am.
Okay, because I see this being used in US quite commonly now. I think to bring down the price, maybe.
Yes, ma'am. I feel that natural is better.
Yeah.
People do use, ma'am.
Sir, one thing was the levels of P4, you said less than 1.2. Now, if they are on the higher side, what is your suggestion? I mean, on the day of transfer, you have said, no, if we don't start progesterone, unless the levels are less than 1.2.
Now, if they are more than 1.2, I mean, shouldn't we be starting if the endometrium is good and the blood flow is good and
What we do nowadays, what is our worry is when you're dealing with the yes, ma'am, I would like to make a comment. Madam is here. Make a comment.
Pankaj, on the day of transfer, what do you think our progesterone should be there?
Ma'am, the day of transfer, we have never checked their progesterones. We have never checked on the day of transfer. We do it one day before we start. We check it, no, ma'am.
yeah.
So, ma'am, my issue is that as per the guidelines, also, in my whole career, I've never used progesterones. P4, I've never done it. But now, when so much of awareness, the type of clientele we handle, they say, "Ki, sir, hamara P4 karo." So when I do the P4 will come in two values, two grades, ma'am. It'll be too low. It'll be 0.02, 0.04 on the lower side, nanograms per ml, or it may touch 1.8, 1.9, or 1.3. So what, as per the guidelines, they say we can go till 1.3, tak we can do. So I have cut a line between 1.2 and 1.3. Now, what do we do? That's the answer I'm going to give to you now.
This progesterone should be on the HCG day or
It
which
is
day?
frozen
Frozen
cycles.
cycles we're talking about, ma'am. Frozen cycles की बात कर रहे हैं, madam.
Achha.
So इसके अंदर I always feel that progesterones, my cancellation rate has gone high after we do the.
So you cancel the cycle, sir.
But pregnancy, cancellation is going high. Now there are two things I like to tell all of you, since we have around 175 people. I like to give you my experience of where I have failed, ma'am. Nowadays, when we use a particular brand of, so estrogen I have not spoken about. That is also part of the endometrial preparation in FET cycles. I am finding that your brand of estrogens are also causing problem. So initially we were giving estrogens for 12 days. Aankhein band kar kar. So my guru taught me give it for 12 days. So for 12 days we used to call the woman, see, look at the endometrium and then titrate up or lower, maintain. Nowadays I'm finding that so many types of estrogens are coming in the market, and even good brands are causing premature endometrial growth. We find that on day 7, day 9, day 10, if the endometrium touches 9 millimeter, it becomes secretory. Ma'am, did you find this? I don't want to name the brands here. I have to stop. Many brands have stopped now, and finally I've settled on one thing. Initially, we were calling patients on day 13 of starting. 12 days of estradiol, 4 days plus 8 days. Call them on day 13. Nowadays, I'm calling them on day 10. Because I had a cycle cancellation rate of around 15 to 20% in the past few months, when the endometrium was hyper mature. So what suggestion I give to all of you is, in the FET cycle, do your endometrial morphology assay and the ultrasound on day 10 now, because everyone is making these hormones now. Because come made in India, no, everyone makes it. And I don't know, I had a bad experience, probably other people may not have had it, but I have this experience. So call them on day 10. And I always carry out P4, because our clientele demand P4 nowadays, but in the army, I've done thousands of cases. We never did P4. We only believed in the morphology of the endometrium. Morphology is good, blood supply is good, we used to go ahead. But nowadays, sir, people may ask you, my cases come negative. I went to some other doctor. I went to Dr. Shubhada. She's the best in the country. I went to her and she said, P4 nahi kara. P4 kyun nahi kara? So, sir, you have not done my P4 and my cycle has failed, and immediately is going to go on Precto and write my treatment was not, P4 was not done, and probably P4 was very, very high, and Dr. Talwar did my embryo transfer. And see, I failed. Refund my money. So many things, I'm telling you, I'm sharing my failures. It's not my success, it's my failure that we get threatened by these things. But P4 karna behtar rehta hai in today's world, because people are because they pay money. They say, do the best for us, we want a pregnancy.
So sir, then in the next cycle, will you be doing an early P4? Because then if once the P4 is very high at this day 12 or whatever, then next cycle maybe day 10 and then transfer early.
I had so much of fights with my patients, a few patients, same thing you're talking, exactly same thing you're talking, what my patient said. So I've said I've converted to day 10 now.
Okay.
The brand which I stopped of drugs is a top brand of the world. I've stopped it now. I don't use it anymore. That was giving me continuous problem, continuous cancellations, one after another. Probably the batch was bad or what. So now I see, ma'am, the P4 will only go high when endometrium touches 8 millimeter. Before that, you won't do P4, no?
Yes.
So initially, my experience was that 8 to 8.5 millimeter triple layer vascularity of zone 3, I would get on day 12 or day 13. But some brands I was getting on day 8 or day 9 or day 10. So that is an issue. So that's what I wanted to say.
And sir, sometimes people I have seen are giving more progesterone. I mean, they are giving 800 plus 50 milligram gestone. So does it harm in any way, or it's just going to be wasted?
It is wasted, and people will have to. There are natural microRNAs progesterone. It may not cause any harm. The side effects of progesterone are always there.
Side effects.
People are paying, no?
Yeah, that's true.
So
I mean, there's no justification why they give. They just give it. Some say if it is very thick endometrium, maybe more than 1.2, give more progesterone. Is it the way?
I don't do any embryo transfer in case endometrium is more than 1 millimeter, 1 centimeter. I don't do.
Yeah, 1 centimeter. Sir. And would you be doing a repeat progesterone post FET?
Repeat progesterone? No, never.
No, never. Never. Not required.
Not required.
So what about?
Thank you, sir. Sir, it was very nice. Sir. The lecture was very nice.
𝐿CG and E2 support in FET cycles?
What, sir?
𝐿CG and FET support?
No, people give. People do give. I've told you I've told you what I don't give, what people give. People give support with agonist. People give support with HCG. They give HCG of 2000 or even 1000. They give it every alternate day, third day. I don't do such sort of practice. I keep my.
Few people are giving weekly till sir 9 months, 8 months HCG.
People give. So I can't stop them. No, HCG should not be given after the presentation is. So HCG should be given in early pregnancy till around 7 to 8 weeks. After the heartbeat has come, presentation has occurred, since CTO trophoblast has formed, I don't give.
But sir, in a FET cycle, there is no corpus luteum, so there's no role for HCG.
No role at all. I'm just saying people are giving that.
Okay. Sorry.
I agree. Different people are giving many things. So I have told you what I give. And we're continuously maintaining pregnancy rate of around 50 to 55%, which is a very humble rate. So we don't make things complicated, man. That's what I'm trying to say.
Estrogen in luteal phase, sir, for FET cycles. Estrogen.
Dena hai na? You continue till 70 days. I give it till 70 days.
70 days.
Yeah, I give 2 milligram at the dose. I normally my 90% of cycles are 2 milligram of estradiol. I will continue at 2 milligram TDS till 70 days. I don't stop it.
Maximum how much you will give, sir, for ET preparation?
People go till around 10 milligrams a day, 10 to 10 milligrams a day. I am comfortable at around 6 to 8 milligrams per day. But people have gone till 10 milligrams per day. Also, people give oral. People give oral also. People give local application also. It depends upon Dr. Bauman. Everything is different. So in a normal forum, when we come to your classes, we'll talk about these things. बहुत बातें करते हैं इन चीजों के बारे में हम. But in a open forum, I'll say that 6 to 8 milligram, 10 milligram is what I go maximum.
Like progesterone, can we use estrogen vaginally, which has a good absorption?
Estrogen vaginally मैंने कभी इस्तेमाल नहीं करा है. I've never used it actually. I have only done transdermal and I've used oral. In case somebody has any experience, and Dr. Bindu may be having from Subject Hospital. Dr. Bindu, any experience of vaginal? I don't have, but anybody else can.
They promote that you can put estrogen hemihydrate vaginally also, but I have not used it. The same oral tablet can be used. They say, but we have not used it.
Not used them. I don't have any experience, ma'am. Ma'am, vaginal is a very bad route for the modern woman. See, modern woman is working around the clock. She's in the office now. She's going to go to the washroom to put vaginal tablet and they start leaking and discharging. It's not a good thing to do.
Yeah, many people, they don't like it.
It's a very messy thing, ma'am. So I think the choice will be entirely by the individuals, ma'am. But vaginal is a good route overall. I prefer vaginal and intramuscular.
One question,
excellent session,
Pankaj. Dr. Pankaj, I just wanted to know, in FET cycle, what do you really prefer? Are you towards your natural cycle, or are you still going for the HRT cycle, or you're using both?
Ma'am, I 99, when the endometrium tends to be poor and the cause I don't know, I may go to natural cycle. When I don't know the cause, endometrium is not forming, I go to natural cycle. But otherwise, I always go to
HRT cycle. People are using agonist down regulation. Do you use it?
Yes, I use in the bad cases of endometriosis, bad cases of PCOS. I do use once in a while. I do use.
Do you use a single dose of depot preparation or the multiple injections?
Ma'am, both options are there, but I prefer to use, I give them, what I do is, ma'am, I give them Malayan or overall or whatever is available. And from day 21, I down-regulate them with leupride or decapeptide. I do that, but not very frequently. It's a not
leupride, decapeptide, depot or the daily dose?
Daily dose, madam, daily dose. In a bad endometriosis patient, I may give a dose of depot and then I continue with down-regulation. I have 1 or 2 cases which I'm doing, but that occurs very rarely, once in a year or twice in a year.
But I also found that was very good in a case of adenomyosis or in the case of endometriosis. Endometriomas are there. So if you give a depot preparation in the first day of the previous cycle and then down-regulate both together, the results are very good.
Very, very nice. I fully agree with you, ma'am. Fully, but that adds on to the expenditure of the patient, and we have to see. But it works well. I do use it, ma'am. Same way, the way you use it, I use it.
Now they are saying the natural cycle avoids the FET cycles. If you use natural cycles, the formation of corpus luteum, it helps in avoiding preeclampsia and big size baby.
Yes, ma'am. Yes. There are, ma'am. It's a continuously evolving science, ma'am. What I see, ma'am, you are doing IVF from, I think, 90s. I started in 2000s. So you would have found it actually evolving over a period of 30 years. Mine is 20 years. So you can write.
But still, still we call ourselves in infancy of ART. Don't you think so? We are still in infancy.
Yes, every day we are learning. Every day we are being battered, actually.
One thing comes and the second day it goes off. See, now the PGTA, they say, oh no, there's a mosaic. You have to put the mosaic embryo. Everything, the reverse is coming. Every 2 months, you see the things have changed.
Gee, ma'am, you're right.
So I want to just want your attention towards this chat box. So please open this. And we have first question of Dr. Sumita Arora, ma'am. So can you please open the chat box?
I'm open. I'm going up.
Yes, sir.
Acha, okay. Constipation, muted, sleepiness, thermogenic. A lot of good answers. But there are 70 comments are there.
Right, sir.
Acha, okay. Dr. Sumita.
Yes, sir.
Sumita, this will be covering, we're going to bore you in the classes. Sumita.
Okay, sir. Thank you.
We have around 4 hours on this. See, what I'm telling here is very different. But we're going to follow every line, every color we're going to follow, and you'll get sick of it. It'll break your heads. We'll cover it up.
Okay, thank you.
And you are going towards, class will be this week only for you. It's around 4 to 5 hours on this physiology.
Correct.
Yes, sir. So
Yes.
we have one more question of Dr. 𝐾𝐻𝐿, and she's asking, please tell me about luteal phase support for IUI cycle, which you already covered up.
Yeah. For IUI, we don't give any support at all until we have given, we have not given 𝐿-𝐴𝐻. When we give 𝐿-𝐴𝐻 or FSH, we give luteal phase support. Otherwise, we don't give any luteal phase support.
Thank you, sir. So next question is from Dr. 𝐏𝐚𝐿𝐞𝐚, and she's asking, sir, can you tell again why HCG to be avoided?
HCG is known to cause ovarian hyperstimulation. So when we start giving HCG, until you are mature enough, you'll give HCG to nearly every patient. And when we give HCG has got a half-life of nearly 4 to 5 days. You'll keep maturing the smaller follicles. When they mature smaller follicles, the patient can go into ovarian hyperstimulation. So HCG is in fact a contraindication when we're carrying out an IVF.
Sir, can we give it later on?
But are not required, Megha, not required. I always tell you, our learning should be very simple. Some people just pump in GnRH agonist shots here and there. Some people pump in HCGs. So they are becoming exotic. No, they are. I give. So this is not a very recommended technique. In case you follow what I've told you today, it's very in very simplistic terms. You won't fail. See, there's something called need to treat. NTT. Need to treat. In case you're giving a drug to a person for say 100 cases, we should get around 20 cases positive. Only then it will become relevant. Like laparoscopy, we were doing laparoscopy for all initially in IVF. Now we stopped doing laparoscopy at all. We don't use laparoscopy is not done in IVF anymore until it is operated. So the need to treat to diagnose a problem with laparoscopy is 1 in 28. 28 cases को ladies को Geeta ma'am, am I right? Dr. Vaughn, you're a laparoscopic surgeon. Amit sir का है. Dr. Amit, can you comment upon this? Dr.
Yes,
Amit?
sir. Very true.
Yes, definitely, sir. It's not indicated at all left, right, and
Yes,
center.
Amit sir, we want your just Amit and Vamini both are robotic surgeons and big people. I left my laparoscope 10-12 years back. So both Amit and आप बताएं इसके बारे में. What is your opinion about need to treat?
Hysteroscopy we can, but laparoscopy not at all needed.
Hysteroscopy also nowadays with a very good ultrasound scan, we get a lot of information. But yes, in suspected cases, or if you feel that they're not the response has not been what you have been expecting, hysteroscopy is a must.
Is a must. Yes, so I agree with both of you.
Even hysteroscopy, they say unless and until the cases of repeated implantation failure, you can have it only by 3D ultrasound and good volume, good Doppler that can show you.
There was this rationale also just which was clubbed with endometrial scratching, and that is what they try to justify with hysteroscopy in all the patients, which does not hold good. But if the ultrasound is suspecting of something else, which you will be doing for a long time with the patient, from the start, from the day that the patient comes in, you will be looking at the endometrium and the uterus closely. And if you're not happy with it, you have to put in a scope inside.
Very good. I fully agree with you. And by the way, Dr. Vaughn also agrees with this. You both
Yes, very true, sir.
So all specialists are now going for low cost IVF. To reduce the cost, that is the biggest thing now we are doing. Everybody is wanting that how to reduce the cost and give the best results to the patient.
Very right, ma'am. Very right. So I'll just see any more questions.
Yes, sir. There's sir. There are 2-3 more questions left. So Dr. Kavita Baranwal, she is with us, ma'am. So she has put a half question. So I just request her to please ask her question. Her question is, out of 3 injection forms, which will be the best? So it's a kind of incomplete question. Dr. Kavita, you are around?
I prefer intramuscular. I prefer intramuscular progesterones.
Okay. How do you counsel them when they're having so much of pain? What do you say? How do you counsel?
Ma'am, actually, intramuscular injections are not very painful in case you give it properly. The people don't give it IM. It should be given deep IM. So in case you give it, अगर आप देखेंगे मैम, अगर आप उसको ऊपर दे देंगे ना, so then the abscess forms. You give it properly. This is my experience. I mean, once you give it properly, the chances are that she may be able to sustain it, ma'am. This is my experience. I've had in my career, I've had around 5 abscesses enough around 17,000 cases. I've had all with intramuscular. I've had around, I think, 3-4 abscesses I know. Probably 6, 7, 8 or 10 I wouldn't have known also. They would have not come back to me also, but not many abscesses form. But
many of them are only sterile seromas type of thing, not abscess.
Hanji, very right for correcting me, ma'am. Very right. Yes, yes ma'am. I spoke about IND where we have done 3-4 we've done the IND.
So there is a question from Dr. Meenu, and she's asking, is there any difference between role of CC and letrozole in preventing LPD?
Whose question is this? She's part
Dr. Meenu's question is this.
Dr. Meenu is part of our classes or not?
She is that, yes.
Meenu is part of our gang, na? ICIT gang?
Yes. Dr.
Then I'll cover up. This is a long talk. I'm going to cover her up. This is not pertaining to this. We'll have around 2-3 hours on this topic.
Right, sir.
After 1 week, we'll be covering for their batch, new batch.
Right, sir. So
that's it. I think I won't hold you with 9:58 and you all be cursing.
Only last question I want to ask, Pankaj, how much you have experience regarding dual stimulation?
Ma'am, dual stimulation, मैंने 15-20 केस किए होंगे मैम total.
So what was your experience?
Very good embryos we get, and there's not much of a difference. Actually, it's a good method. It's a good, but it's not an. It's always to be done with good amount of counseling, ma'am. I mean, it's not that we get 10 eggs from both the dual stimulations. We get 4 embryos. It is not like that, but it has to have an indication, not for a routine. I won't recommend it for a routine IVF patient, but for cancer. Where basically cancer ke liye hota hai, ma'am, and that too breast cancer, or Hodgkin's. They work well, ma'am.
Okay.
It's for fertility.
The trigger you use is a GnR agonist.
Yeah, agonist. Always an intact cycle with that, because you have to keep levels of E2 low. And many times I combine letrozole also. I combine letrozole and HMG.
Yeah.
It's the best thing to do. We keep levels of E2 low in fertility preservation. I think it's good. I'll stop it here with your blessings, and I hand over the mic to.
Very nice.
Thank you, ma'am. Thank you for joining us.
Hi, good morning, sir. Hi, good morning. I'm Dr. Sita Sharma. I'm not able to be in Zoom. Hello, sir. I want to ask one question. Why does this P4 level rise on the day of trigger? I have seen many patients showing P4 level more than 1.5, and the cutoff value is 1.5 to go for a fresh embryo transfer. And the same when in FET cycle we are giving only estrogen. Then why does this P4 rise?
I don't have such experience. Why does P4 rise? Probably P4 can only rise when she's got a cyst around. She may be having a cyst which has been missed initially, which has grown. Normally, when we are giving an FET cycle, HRT, I have few colleagues which come and tell me, I've seen it also, that when you're giving an FET cycle, this is a cyst ban gaya. See, cyst will never form till the time you have taken an ovarian follicle of 4 to 5 millimeter. When sometimes we don't look at the day 2, day 3 scan properly. Normally, when we give an HRT, all the cysts are suppressed. We give OC pills or estrogens to suppress the cyst. Cysts cannot form on a HRT. This is my experience. But few of my colleagues do come and tell me, sir, cyst ban jata hai. So I say that probably it's the wrong case selection. This is my experience. Anybody can take the call on this. I mean, this is all I can say, that in case we do proper selection, cyst won't form.
Sir, but in case of ovarian stimulation, in case of IVF, that means we have to work on the drugs we use for ovulation induction?
I didn't get your query properly, Dr. Sita. Can you please talk?
Yeah.
Take your time. Take your time.
When we start stimulating the patient for IVF,
okay,
and on the day of trigger, we usually do E2 and P4.
Yeah.
And if we find P4 is more than 1.5, or sometimes it is more than 3 also. So what is the cause behind that P4 rise?
P4 rise, you're doing P4 on what day? The day of pickup?
Day of trigger.
Day of
HCG trigger.
हाँ तो जब आप HCG देंगे, when you give patient an HCG, normally we don't carry out P4 in the OPUs. We normally are doing P4 for the FET cycles only.
Okay.
We don't carry out an OPU cycles में हम सिर्फ E2 करते हैं, P4 हम नहीं करते हैं. I don't know. So I don't have any answering this query, but I'll answer it logically. We only do P4 in the FET cycles. On a routine transfer cycle, we only do E2. We don't carry out even E2. We don't do. We do morphological assessment. We do E2 only when we are finding that for medical legal purposes we have to cover ourselves up. Otherwise, as I have told you, that a follicle will one follicle has got 250 micrograms picograms of E2. So we come to know how much E2 will be there. I don't carry out E2 routinely for that. But after you have triggered the patient, you've given the patient trigger with the HCG. Definitely LH will come, and when LH will come, it will break the follicle and P4 will come.
That's right, sir.
Sir, good morning, sir.
But don't do it for OPU cycles. Do it for FET cycles. This is what I advise you.
Okay, sir.
Sir, good morning, sir. It's Ishrat here.
Hi, Ishrat. How are you?
Sir, I'm fine. Thank you. Sir, I want to ask you a question, that is, in case of OPU cycles, fresh cycles, we are doing E2 and P4 on the day of trigger, before giving the trigger. It is routinely we are doing.
Yes.
So is it not mandatory to do the P4?
That even E2 is not mandatory here. I have told you, as per the guidelines of FSHRE, none of these things are required. Because in case you do, yes.
Sir, we are doing to predict whether there is a chance of OHSS, or there's too many follicles are formed, and then the E2 level is too high. Then there is chance of OHSS, or the P4 level is high, so we are not transferring. What is the right way to monitor?
Nowadays you're going in for a 95% of FET cycles. So when we're doing FET cycles, so this means that we're going to freeze our embryos. We want to freeze our embryos, and why do P4? P4 is not required. You want to do freezing of our embryos. Then you're not going to implant them. So P4 won't be required in around 90% of cycles. You're getting my point?
So, sir, if we want to do fresh transfer, then should we go for E2 and P4?
I don't think so. I don't think so that you should be doing P4 for every patient. E2, yes. E2 you can do for every patient in case you want to do. But even E2 is not recommended here because some are not very fond of doing hormones. Because this will increase our pricing by around rupees 2,000. So hormones are not recommended in case you do a good ultrasound and you find that her follicles are how many. You can calculate, have a rough idea about her E2 levels. Doing it for all, I don't agree, and we don't do it at all.
Sir, we are depending on E2 for the triggering agent also, because if the E2 level is very high, then we are going for HCG and also the Ovidrel, that is recombinant HCG.
No. I'll tell you one very simple thing, Ishrat, for all of you. One simple logic you have to know that whenever we are doing any cycle now, we are not doing a long protocol. We are doing a short protocol. We are doing a protocol with antagonist. And antagonist protocol means that we are doing triggering with an agonist. For nearly 99% of patients, we are giving agonist protocol, agonist trigger with antac cycle. And when you give an agonist trigger, at least past 2-3 years have never had a case of, not even a single case of ovarian hyperstimulation. So you have to change the way we are working. We don't monitor a cycle by doing P4 and E2s, but I suggest all of you, you are 101 people with us now, so many of you are very senior, simple understanding you have that you do only ANTAG protocol. Do an ANTAG protocol, learn how to do an ANTAG protocol, trigger with agonist. And then you won't have any ovarian hyperstimulation. You'll never have. And when we do an ANTAG trigger, in nearly 100% of them, we are going in for FET cycles. So next month you can carry out their embryo transfer. When we do embryo transfer, that time we carry out P4. This is a practice which is being followed all over the world. In case in an ANTAG cycle, you are doing embryo transfer, you have to give very aggressive support of progesterones. People give HCG, people give intramuscular, people give vaginal. And this is not required. So in case you get a simple trick you do, ANTAG for all, agonist trigger with decapeptyl 0.2 or 2 milligram of leupride, you'll never have any ovarian hyperstimulation. And still you are scared in that patient. Just after you have done the trigger, after taken out 20-30x, immediately give her a dipoprogesterone and start letrozole. Ovarian hyperstimulation is 0 in my past 4 to 5 years. So this would be my answer. In place of correcting what you are doing, I will say correct the protocol and you won't require all these complicated things.
Hey, sir, I have seen many patients, many persons, many doctors, using agonist on the day of FET, frozen embryo transfer. Is there any role of that?
Many people use, ma'am. Many people like to give agonist because when they give agonist, they say agonist will bring out some immediate surge of
Okay.
People are using. So I'm just saying that we should not be having. See, these are all very controversial things which people do. They have some RCTs, some have some documentary evidence. But in a class like this, or in a practice also, keep it very, very simple, man. Why to complicate things? And in case you just give 2 types of supports, you can easily achieve pregnancy rate of around 50-55% on average. You should only when to start. When to start, the support is the thing which is very important. Start kab karna hai, band kab karna hai is the thing which is of relevance. Now in FET cycle, people make mistake on the day of embryo transfer. Some people do embryo transfer on wrong days or wrong times. That can lead to problem. But I think any 2 supports you pick up, the good support for the new generation can be a vaginal support, which is 200 milligram sustained tablet. You can take sustained tablet morning, evening, 200 milligrams, along with you can get 50 milligrams of subcutaneous progesterone. Or you can take aqueous plus vaginal gel, or you can take aqueous or NMP vaginally, along with you can give oral intramuscular or subcutaneous. You can also add oral plus vaginal, deficiency or dydroboon plus vaginal. So 2 supports is what I recommend for the complete safety. I am not happy with single support. That's the only thing you have to do.
Sir, what is the best time to transfer? If you are giving the injections in the afternoon, say around 3 o'clock, 3 p.m., you are giving the injection to the patient. And if we want to carry on day 3 transfer, then what should be the ideal time for transfer?
I just tell you, I think we had with you the class on FETs. With your batch, I don't remember. Just remember that in case of the day 3 embryo, do the transfer on day 4.
Yeah, that's right, sir. What it should be like, it is given at 3 o'clock, then is there any relevance to the time or within?
Fine. I'll answer. This is a very, very nice question you have brought out. I'll tell you what I do. So suppose today I do all my ultrasounds in the morning at around 9:30, 10 o'clock or 11 o'clock.
Right. Yes,
so
sir.
आज है 15 तारीख. आज मुझे पता नहीं क्या तारीख है, 16 तारीख है.
16 है सर आज है.
तो 16 तारीख को I planned that her endometrium is ready. So 16, 17, 18 are the full days for her of injection.
Right. Yes, sir.
और 19 तारीख को सुबह around 6 o'clock I'll pour the embryos and give one dose again.
Okay.
लगा दिया और चौथा डोज लगाने के 2-3 घंटे के बाद I do her embryo transfer. I normally don't go the whole day.
Yes, sir.
By midday, after 4 hours of injection, I do that. But I give that injection in the morning at around 8:39, and by around 12 o'clock maximum, I do the embryo transfer.
Okay, thank you, sir. That is so nice.
Working formula, I'm telling you. Working formula.
Okay.
Sir, I just want to know, you said the best is anti cycle with agonist trigger. So you do FET in the very next month, or you give a 1 month gap?
It all depends upon ma'am. It depends upon her. In case she's got any retained ovarian cyst, I cannot, or a corpus luteum, I don't do. She may have to wait. So suppose today we have given her a trigger and done her ovum pickup day after tomorrow, then there is no support in this case. After around 8-10 days, she'll get her periods. So when she gets her periods, I like to avoid doing FET in that cycle, though around 60%, 70% people do, but I avoid. I'll give her this break of 1 month, and then next day 2, I will do her case. But I want
Thank you, sir.
To be very clean. I want pelvis to be very clean. This is the point.
Thank you, sir.
So we, I know it's very, time is actually very much. But we have an international doctor and we generally don't give interaction. So we have a question from Dr. Davis and he's alumnus from Nigeria. So he wanted to ask a question, is there a role of luteal support in PCOS?
In PCOS, luteal support is, first of all, in PCOS in IUI. PCOS in IUIs, she'll have large number of follicles in case you have given chronotropins. So in IUI, even with sometimes clomiphene, I have told you when she has more than 2 or 3 follicles, we should give support. IUI in PCOS with letrozole, no support. Single follicle is there. With clomiphene, when multiple follicles form, support should be given. In IVF, Dr. Davis, in IVF, in PCOS, always carry out frozen embryo transfer cycle. It's an FET cycle. So support will be given in the next month.
Sir, is there any role of metformin in case of luteal phase support?
No, metformin is not for luteal phase support. Metformin is basically to reduce chance of ovarian hyperstimulation.
Good morning, sir. Dr. Swapna.
So yes, I'll take the last question. There's the last question that I'm going to stop because it's too late for all of you.
Yeah. Yes, sir. Actually, the fresh cycle after doing OPU, you said 1 month gap you'll be giving.
Yeah,
so in that 1 month, do you down-regulate the patient, sir?
Nothing.
Okay.
Only I give folic acid, ecosperin, arginine sachets I give to the people.
Okay. And again, the subsequent cycle on day 2 when she comes, do you check whether she has down-regulated or not?
Yeah, that
Yeah.
her ET should be papery thin.
That scan anyway will do, sir. But do you check the hormones like P4 and LH? Not required.
Never.
Okay.
I never do any hormones. I'm only hormones at one point of time, and that hormonal testing I'm only doing that too because patients are demanded now, and then in case they come negative, they raise a query. Only before FET cycle, before
Okay, sir.
1 day prior to their hormones. Before
Okay, fine.
So that's
And for
complain. Otherwise, I never do.
Okay. Okay, sir. Sir, for FET cycles, do you down-regulate, sir, regularly as a routine?
No. Until it's a bad case of endometrioma or say she's a
severe PCOS. Okay.
2 conditions.
Okay. And 1 day yes, sir. And 1 day prior to embryo transfer, do you check progesterone levels, sir?
Yeah, I always check. No, not
1 day prior to embryo transfer. No. Okay. So prior to starting a progesterone injection, you'll check it.
Exactly.
And ideally, it should be like less than 1. 1 we take cutoff, sir, or 1.2?
I take 1.2. Some people go to 1.4. I take it at 1.2.
Okay, sir.
And there is no lower limit. There is no lower limit.
Okay, sir.
0.4 is okay.
Okay. And few cases, what I have seen, sir, like on scan, there is no cyst as such. But 1 day prior to starting progesterones, when I check, it is coming more, like 2 or 2.2. But on scan, there is no cyst as such. In those cases, actually, I'm cancelling, but I don't know what could be the reason.
I also cancel because I'm due to give the outcome. I also
Raleigh Central Line.
Okay, sir. Okay. Sir, for severe endometriosis and PCOS, we do down regulation, no, sir? So is it like, from day 1?
Not always.
Not always. Severe cases. So on day 1 of periods only, you are giving of depot injection, and from 21st day, you are giving daily lupride injection, sir?
Yeah, you can give a depot followed by short acting, or you can give OC pill plus short acting.
Short acting. Okay, sir. Yeah. Thank you, sir. Thanks a lot.
I think we'll stop here. It's a long time, nearly 2 hours.
Yes.
I don't want to bore you more.
Yes.
So,
Thank you, sir.
Thank you, sir. And sir, I wanted to both of us should say hello to all our Myanmar, Philippines, and Nigeria, Uganda friends, because in such a big crowd, we cannot actually say hello to all of you. So hello, everyone. I can see a lot my friends. I cannot take the names and my seniors. Thank you so much for joining. It gives us a lot of courage and enthusiasm and positivity for such things, and for sparing so long hours with all of you. So thank you so much, and we'll come up with the next topic on azoospermia on the next Sunday and next to next Sunday, and we'll keep updating you about our program. Thank you so much. And thank you, sir, for the wonderful talk.
Thank you very much.
Dr. Amit, bye. Bye, everyone. Bye.
Thank you.